Okay, so the objectives this morning of this part of the talk is how to explain anatomically how human development can result in obstructive sleep apnea. And then it's basically going to be a review of anatomy. And the point here is that the physiologic imperative to sleep can be as strong as the drive to breathe. The drive to breathe is extremely strong. It's the overruling impulse. So what happens and why does human beings get sleep apnea? Let's talk about what it looks like.
Is it my imagination, or are we really starting to get the hang of this?
Yeah, it was pretty terrific.
For a while there, it was like we were in the zone, working together as one and anticipating each other's moves, like the '05 White Sox.
Is that why you kept coming and take me out to the ball game?
I had to, otherwise I'd have laid down a bunt before I left the dugout.
Do you mind if I finish up a little bit of work for tomorrow?
No, by all means, go ahead. It's important that you feel at home here.
You sure?
Yeah, we just shared the most intimate thing two human beings can share. At this point, cracking open your laptop is almost redundant.
Well, thank you. Good night.
Good night.
Sleep tight. Don't let the bed bugs bite. Which isn't as funny as it used to be, because I had this kid in my class that was... Whoa.
If this is a turnoff, I could do without it.
No, I was a little startled, but it's fine.
I know it looks a little strange, but it does keep me from snoring.
Which is what makes it so hot. Please, leave it on.
Okey doke. You know, you can get different colored head straps. I went with basic black.
Nice. Very slimming.
Good night, Molly.
Good night, Mike. Perfect. The gun was right there.
She goes down for my lady. No more splash landings. Morning, my little turtle dove. You making Papa Bear a cup of coffee?
Absolutely, Papa Bear.
Hey, did Goldilocks sleep out here last night?
Yeah, your bed's a little lumpy.
I guess it would be. It was my mom and dad's old bed.
Okay. And so, it's funny? Yes, it's funny. Does that happen every day? Yes. Is it funny when it's happening to her? No. And so, does this happen? Could it happen exactly like that? Yeah, it's really cute. So, okay. Let's look at this one. This is very interesting as well. Let's see if this is, there we go. Rick, this is the waking, gasping, choking, die in your sleep syndrome. There it is. No comedy series. This is it. Mouth is open. Arousal, not awakening. And think now, what's happening to the brain, what's happening to the rest of the system when it's happening 60 seconds? So later on today, Rick will go over this, and pay close attention on that score sheet to the mean time. Isn't it mean you give? Mean apneic time. And when you see something like 25 seconds, it's twice as long as that. This is scary stuff. You know, I went to dental school. I got out of dental school. And I was really happy because you can't kill a patient. And that was pretty good. You really had to be terrible to kill the patient. And then the guys across the street, they went to the medical school. They had to get out of school and learn anywhere from 550 to 750 diagnoses. I got out of dental school, 5 diagnoses. That's pretty good. Tooth decay or not tooth decay? Pyorrhea or not pyorrhea? Root canal or not root canal? Extraction or not extraction? Life was good till we got sleep apnea. Now, the patient could die. And is it within the scope of services or usual range and scope of services that we do a screening for this? Of course it is. If you don't do it, is that negligent? Well, maybe they can't lay the blame directly on you for not doing it, but we sure have a mandate here to start treating this stuff. We're already doing the cancer exam. We're looking at the same tissues, and all of a sudden we got to start seeing it. And we're going to see these patients on a regular basis. We have the trust and confidence of our patients. Patients come in to the dental office for a 6-month recall. They come in like clockwork. You call, and they come. This do physicians, they're jealous. They can't get them in at the regularity that we do for a 6-month recall. And so we really have the trust and confidence of these patients. And again, I take it as a mandate that we should be looking. If we're already looking at the same tissues, we should be looking at the way these tissues function in terms of, do our patients have sleep apnea? Okay, so much for that. Now let's go back to slides. There we go. So the oral pharynx is a conduit for 3 completely different functions. Swallowing, food and liquids go from the oral cavity to the esophagus. It's breathing, transporting air to and from the lungs, and phonation. Formation and transmission of the vowel sounds in speech come from the throat area, the oral pharynx. So, infants and lower animals, swallowing and breathing can occur together. In adults, as we sit here now, we can't swallow and breathe at the same time. And that's what we're going to talk about, is that mechanism. So, here's a child's anatomy. And this is very similar to the anatomy of animals in that when you look at this picture here, the epiglottis extends behind the soft palate and uvula. So this is the uvula here. And when Frank Netter did this drawing, kids had blue tongues and uvulas. But now they turn pink lately. So anyway, here, this is called locked epiglottis, this arrangement. And so you have to see this here. What's happening is air is going in the nose and liquids are going down, shunted around the sides. And so this way a child can breathe and swallow at the same time. So this is really important stuff. And so here's a question. See, because what happens is we have this rest here. And so children don't suck to extrude the milk. Children suck to attach to the breasts, okay? And so that's all it is. It's an attachment, And then the child nibbles to extrude the milk. Or the mothers, a lot of mothers have extrusion reflexes. There's mothers who think about nursing and can extrude a shot of milk halfway across the room. And so that's another mechanism. But that's a hormonal thing, and it doesn't always occur. It's basically a nibbling mechanism. And so the child can breathe and swallow at the same time. This is really advantageous. So we have the breasts. Anybody want to tell me why breasts are shaped like that? The answer is not because they attract men. Now, who wants to tell me why they're shaped like that? All right, I'll tell you why. They're shaped like that because when a baby is born, human babies have basically flat faces. Human skulls are roughly 3.5 times larger than the next nearest animal because they want to put a lot of brains in there because we all like our kids to be smart. And so what happens is when the kid comes out, because they got to go through a birth canal, and this birth canal can only expand so much, so the baby comes out, and babies are designed to have basically flat faces. So if you have a flat-faced baby, and this kid doesn't have a breast that's shaped like that, then it's sort of like sucking on a piece of glass to try and attach. And so the breast is shaped so that the kid can attach and extrude the milk. Whereas you see some animals that have this flat, and all you see is a nipple coming out, those animals have what's called snouts. So if you got a snout, you can, breastfeed off of an animal that has a flat chest. And so basically the reason breasts are shaped like that is so that the kid can attach, not to attract their mate. They've done studies on this. There's a really cool book now called Breasts, a Natural and Unnatural History. And so you get these little factoids if you read the book. Okay, this infant and lower animal, the arrangement is referred to as locked epiglottis. At 6 to 12 months of age, the uvula begins to ascend and the epiglottis begins to descend. And so then we get to the adult, fast forward now, we're in an adult state. In the adult state, we have compliant oral pharynx, and this is, of course, sliced open. And so our field of action is right in here, looking at it from the back and looking at it from the side. Our field of action is right in here. This is very interesting because for all the attention we're paying to it, it's an area about 1.5 inches long. That's pretty cool. Such a small area to have such a huge effect. An important characteristic that distinguishes humans from lower animals is speech. The collapsible, compliant airway is a requisite of speech articulation. It's because we make all these intricate sounds by manipulating our compliant airway, and lower animals can't do that. The pharynx is the only collapsible segment of the respiratory tract. The tongue is the ventral portion and results in creation of the compliant airway. In adults, the pharynx remains open at all times except during swallowing, regurgitation, or vomiting. The pharynx does not swallow during breathing in adults. Breathing does not occur simultaneous with swallowing. The good news, speech. And the bad news, so now we can get choking, snoring, and apnea. So let's stop for a moment and review the definitions that Rick gave us yesterday. Apnea is an 80 to 100% reduction in airflow for a minimum duration of 10 seconds. Hypopnea, 30 to 80% reduction in airflow accompanied by a desaturation, which you now know what that is, for a minimum duration of 10 seconds. And then we have upper airway resistance, which is less than a 30% reduction in airflow. And these figures, depending on what textbook you read and what article you read or what experiment they're doing, it could be that a hypopnea is 50 to 80, and it could be upper airway resistance is 30 to 50. But a desaturation, again, you can even set your metabite, I believe, a rapid 3 to 4% drop in the blood oxygen saturation level. So in certain definitions, in certain tests and in certain insurance companies, they want 4% drop, and in others, it's a 3% drop. And so it's a 3 to 4% drop, covers the whole range. And then we have snoring. Snoring is interesting because If I say it's an obstructive sleep breathing characterized by a harsh sound, you go, can't you be more specific? No, you can't be more specific. This is the year 2012. This is August. There is no more scientific definition than obstructive sleep breathing characterized by a harsh sound. We have to have three things: the vibrating structure, flow limitation, and sleep. So if I go, that's not snoring. That's the sound I'm making, but I'm not asleep. And it's not always the same. And so when you have these instruments that measure snoring and they say, okay, now say, put this in and we'll see if in that height you can't snore. And they do this, and that's not scientific. You have to have sleep. And so you're faking it otherwise, and we can't fake these phenomena. And so John was asking me yesterday about the pharyngometer. Now there's nothing that gets the sleep disorders department in a medical center more apoplectic than talking about the pharyngometer. And the reason being that what we talked about to take a bite is to create more room for the tongue. We want the tongue, make a mouth, help to make the situation such that the tongue can fit in the mouth. Okay, so what the pharyngometer is doing is it's measuring the area for the tongue without the tongue. So in other words, you can't, if you could take the tongue out and you could do a volumetric study in a beaker and you could dip the tongue in there, you could measure it. But simply changing the position of the tongue to measure the space available for the tongue when the tongue is not there doesn't give you what's going to happen. Because we were talking yesterday and we said, well, what about the tongue fitting down here? And so we have a rationale for double chins. And what they're measuring is the empty space without measuring the volume of the tongue. And to measure that space, they put the tongue is still going to be in the mouth, but they have to force the tongue into a totally abnormal position to get the measurement of the space around the tongue. And this whole thing, there's no science. It blows apart. And so the relationship of a pharyngometer to predicting success of an oral appliance, there's never been a successful study in the literature. The thing has been around. You know how old that pharyngometer is, John? The thing came out that the operating system is DOS. Since DOS, we had Windows 1, Windows 2, Windows 7, Windows. So if you think about it, this is a based on science from the 70s. Okay, so we have obstructive sleep apnea. Combinations of the following contribute to the airway blockage. So how can the airway get blocked? We have flaccidity of the tongue muscles. As you get older, your tongue muscles get more flaccid. And again, what Rick was saying is that you can keep that tongue muscle in better shape. People who play certain wind instruments, there's a study in the British Medical Journal, December 2005. It's I believe it's in your handout, in your stick. And the British taught patients to play the didgeridoo. It was a Swiss study. They taught the patients to play the didgeridoo. And in playing the didgeridoo, they cut the apnea-hypopnea ratio in half. So we can control the flaccidity of these muscles. There's another study done. Katia Guimarães in Brazil did a study where they taught patients myofunctional therapy. Maybe I'll have a couple of pictures of that. And they taught these patients to do certain things with their tongue and strengthen the tongue muscles. And then we have things like hyperplastic redundant tissue. Once you start to snore, for whatever reason, the tissue gets inflamed, the tissues get flaccid, and so we have hyperplastic redundant tissues. We have inflammation of tissues. Then we have things like large tonsils and obesity, where the fat collects in the walls of the oropharynx, and we have smaller oropharynxes in obese people, and so we have a higher incidence of apnea. That's a very tough apnea to treat. You're going to see the picture that he created from this the book, Charles Dickens' book, is everybody has to be fat. It's not so. I have a dental chair like all the rest of you, and the dental chair says somewhere on the bottom, don't put a patient in here more than 350 pounds. And I get these referrals from tertiary medical centers, and I never see these patients because A, they know that they can't, it doesn't work, oral appliances on obese people, and morbidly obese people, and so they don't bother. But I've never been challenged. What the unexpected is you're going to see people who 4 feet 7, 100 pounds. You go, that's a rail, and these people get it too. And so the stereotype, you can't stereotype an apnea patient by looking at them in the street. You'll be amazed when you walk in your waiting room. Who's the apnea patient? You won't guess it half the time. Nasal obstructions, very important. We've been saying over and over again that we want the patients to be able to breathe through the nose. Nasal surgery is far and away the more favored surgery for clearing the airway so the patients can tolerate CPAP or tolerate oral appliances or have less apnea. And so basically here what we're saying is there's two methods. And so one is the tongue can just drop back and collapse on the airway, and that's your classic picture that you saw. The other thing is that when you take a breath through your nose, if you have too many obstructions, you have negative pressure created. And the negative pressure, the Bernoulli principle, carries itself down. It can suck the airway shut. And so John Remmers has done studies to show that sucking the airway shut is an important factor. It's probably neither one or the other, but a combination of two. It's the flaccidity of the tongue, maybe it's the size of the airway, and the suction. So you can suck the airway shut. And again, that makes it very difficult to predict who it's going to work on unless you know how nose is working. The nasal obstruction, very important. Deviated septums. Remember, we have the nasal cycle. Half the time you're breathing out of one half of the nose or the other at an 80-20 ratio. It just shifts. Do you ever have a cold? And then you think you're totally closed, and all of a sudden you hear a little click, and all of a sudden you can breathe. That's the nasal cycle shifting. There's not anything you could do to shift it. It's just, that's the way it works. And about 75% of all people have it, and there's still 25% of people that don't. So nasal cycle, very important also. Dysphagia. If you swallow improperly, where we saw that, I believe, in Jan yesterday, the tongue extrudes out the teeth, and the tongue is extruding between the teeth when she swallows because there's not enough room in the airway to keep an airway open, and so she has an adaptive tongue position that lends itself to a dysphagia. Broken noses, you'll see broken noses on panoramic x-rays all the time. You got to look at the nose, but it's there. Long, soft palates, sometimes they're so long, as we saw, I couldn't see. The Mallampati is very interesting. You see that on your exam forms, and you're going to give it a grade. Mallampati 1, 2, 3, or 4. And they'll say, well, the Mallampati was a 4. And they like it means something. Mallampati was an anesthesiologist. And all he wanted to know when he invented this is, am I going to be able to intubate the airway during surgery easily? That's all. His question is, is there a big hole for me to stick that tube down, or a small hole? Does it have any bearing on airway? Well, it's a two-dimensional picture of the opening of the airway. It has no idea what's going on the sides of the airway. It's the opening of the airway. So when I give a lecture like that at ENT, and all of a sudden the hand goes, what do you think of Mallampati? And I go, nothing. It's a two-dimensional picture of a three-dimensional object. And it's like, okay, you can continue to lecture because they got credibility. That's what they think. And so you need that credibility when you're talking to ENTs. But is a really important predictor of tendency toward apnea? No. That's what I'm saying. When you get these referrals from the physicians, don't try and rule out an oral appliance. You don't know. Okay, long soft palate, large uvulas, retronasia. The farther back the jaw goes, the less room there is for the tongue. Large tongues, macroglossia. Genioglossus incoordination. There are people who have motor nerve problems that can't swallow. And then edentulous collapse. We all know what that looks like. How many patients have had their dentures that you see 20, 30, 40 years? That the ridges shrink, there's not enough room for the tongue. How many denture patients don't have apnea? You know, it's like almost universal that a full denture patient's going to snore. If they're going to snore, there's a good chance they can have apnea. And then we have another condition that we've introduced. Micronathia, 4 bicuspid extraction orthodontics. We call that iatrogenic micronathia because it's doctor created. In my book, if I ruled the world, that would be a felony offense punishable by about 6 years in hard labor because these patients are suffering from that. And so that's my opinion. An acnic event is created by either the tongue or the soft palate or both together collapsing on the back of the airway. And this collapse can be caused by muscle flaccidity and negative airway pressure. That's the two big ones. And it can be caused a combination of both flaccidity and the pressure. Also, muscle fatigue figures in, central nervous system misfiring. We have incoordinations. And, you know, the old wives' tale, the grandmother's tale, it went down the wrong pipe, I used to say, when you're choking. Well, that's probably the most true thing you're going to hear. Central nervous system misfiring, incoordination. And then we have certain pulmonary diseases and certain neuromuscular diseases. So if a patient's got muscular dystrophy, they're going to have problems. And what you're going to find is that when you see Down syndrome kids, they always have macroglossia. These kids have huge amounts of apnea. And a lot of times the apnea kills them. And so what do you do on these patients? You expand the palate. Yeah, they're not pretty, but you're not expanding the palate for cosmetics. You're expanding the palate to make room for the tongue. How much room? Can you make too much room for a Down syndrome kid? No. You're helping them to breathe. You're making their quality of life better. And it's just one of those things. So it's important. Let's review the anatomy. The upper airway muscles involved in reduction of airway diameter. Genioglossus, again, we said the tongue can collapse. Palatoglossus, tensor veli palatini, levator veli palatini, hyoid muscles, and the pharyngeal constrictor muscles. Complicated stuff. We haven't studied this since dental school in many cases. And we're not going to do a head and neck dissection today because we got Frank Netter doing these beautiful pictures for us. So, let's look at these beautiful pictures. Turbinate bone in the nose. And then we have the auditory tuberosity. And then eustachian tube. So the connection from the ear to the mouth. And then that's why when we have these kids with ear tubes, they connect, the ear tube goes from right there, clear out the ear, so that we have the connection. And that's why these kids get these frequent ear infections when they have swollen adenoids, because the swollen adenoid covers this up and causes a stasis, and it causes the bacteria from the nose and the mouth to fester and grow and infect the eustachian tube. Okay, and then we have the salpingopharyngeal fold. And so you see these pictures, and it's nice to know what they are. And then we have the soft palate. The soft palate is interesting as well because it's innervated by the 5th, the 9th, and the 10th nerves. And so that's interesting. When you go back to the branchial arches, and here's the structure that fused from, that's innervated by 3 cranial nerves. Very, very complex stuff. And then we have the palatopharyngeal fold, arch. And so a lot of times you'll see, you'll look in there and you'll look like there's no tonsils. You can't see the tonsils behind the palatoglossal arch. And the palatoglossal arch, again, is a factor in the malum pati. And it has, so you could have this, curtain here, right there, and it looks like it's restricting the airway, but you can have a nice big airway behind it. And so it's not always, this is complicated stuff. And sometimes this is so big that it doesn't make any difference if the tonsils are big or large. You can't see the tonsils behind them. And so the tonsils, again, fit between the palatoglossal and the palatopharyngeal arch. Okay, and then we have genioglossus, again, sensory and motor, 5th and 12th nerves. And then we have the epiglottis. Okay, so the muscles of the pharynx, we have 2 different kinds. We have circular muscles, which go around it, and we have longitudinal muscles. And so the circular muscles, easy, superior, middle, and inferior pharyngeal constrictor muscles. And then we have the longitudinal muscles, the stylopharyngeus, salpingopharyngeus, and palatopharyngeus. So looking at it from this point of view, the pharyngeal recess, salpingopharyngeal fold, soft palate, palatopharyngeal fold. As I said, the palatopharyngeal fold was the one with the tonsillar, the sort of a fossa in here, between the palatopharyngeal fold and the glossopharyngeal fold. Looking at it from the top, Glossopharyngeal muscle, palatal-pharyngeal muscle, and again, get the picture. There's your tonsil fitting in there. This thing will be such a big drape sometimes that you can't see this, and it's there and it's significant. But look at it from a different perspective, how all this can affect the size of the opening. Just remember, we'll show you this on ICAD pictures, and you got to factor in the fact that if these tonsils are large, they can be obstructive, and you're going to see this here very prominently on some x-rays. And so then we have the superior pharyngeal constrictor muscle. Again, a circular muscle. And then we have the muscles of the soft palate. Levator veli palatini, tensor veli palatini, palatal-pharyngeal, and the muscular uvulus. So, levator veli palatini, superior pharyngeal constrictor, is again a circular muscle. Longitudinal muscle, the palatal-pharyngeal. There's musculus uvulae, tensor veli palatini, and of course, tensor veli palatini. The muscles of the soft palate are essential in closing the nasopharynx during a swallow, so there's no reflux of food or liquid into the nose. And so you saw a picture yesterday where Rick showed where they actually did a UPPP, and I was saying it's 42% effective, but what are the consequences of failure? The consequences of failure are huge. Well, the patient will come in and they'll be talking like this, like they had a cleft palate. And that's really quite difficult if they talk like that. And when these guys get, see, that a lot of times they'll say, you know, Doc, it's not working. I still snore. You just did that surgery. We'll do a little more. I may have been a little too conservative. And the next thing you know, that after the third surgery, they come in and they're talking like this. Or the other one is really is you'll see the patient, what's the chief complaint? Nasal regurgitation. Well, what are you going to do after that? When every time they take in food and liquid, it comes out their nose. So they'll go to bed at night and they take a drink of water and they're not quite vertical and it starts coming out their nose because the palate's too short and it doesn't shunt properly. So there's a lot of huge consequences you'll see from that UPPP procedure, and virtually nobody's doing it anymore. It was like it came in and they thought, this is the answer. And so there was a period about probably in the 90s they were doing a lot of it, and then they just stopped. And then again, the surgeons will do anything for money. You know that, and I know that. And so you still see these. And I was once on a panel discussion with a very famous ear, nose, and throat doctor. He ran a 3-day course in Chicago. And so he invited me to be in a panel discussion about ENT surgery, because I was anti-surgery. And so sure enough, we each give a 10-minute presentation. There's about 5 of us up there. And the question comes up, and they say, from the audience, what do you recommend doing for failed surgery? And I raise my hand. I want to answer the question. They look at me like, are you crazy? And then they're all laughing because I'm the dentist and everybody knew that. And then they said, very humored me, let Moses answer the question. And so I said to the guy, well, let me see. You say failed surgery. And then the guy said, yeah. I said, so it failed means that what? The patient, you took out the tonsils by mistake. No. Or the guy had excessive profusive bleeding. No. So why did it fail? Because the patient still snored. Okay. So let's get it straight. It didn't fail. You were just very conservative and it didn't quite work. But it wasn't a failure. Yeah. So what do we do about this? And I said, well, then you need a dentist. Because you've already increased the caliber of the hole. Now you got to get it working properly. And we can rearrange the anatomical structures in a different way. You need a dentist to work with that will know how to understand oral appliances. Boy, they like this answer. Everybody's going to pat me on the back and behind. And I thought, this is really cool. So then, the guy's hand goes up again and he says, this really sounds good, Dr. Moses, What do you charge for that appliance? This is a few years ago. I said, well, I charge $2,500 for that appliance. It's like the Greek chorus. And then he comes back to me and he says, well, he's still standing and asking questions. He says, do you know what we get for the UPPP? We get $800. And I go, to myself, I go, tough shit. Because it either works or it doesn't work. This discussion is not about money. I'm telling you how I can make you look good by performing a very important, conservative, non-invasive, painless procedure for you, and you're telling me it costs too much? I mean, thank you, doctor. You know, it's like, you don't do that when you're at this audience. But there's a certain sense of values, and you're going to see this a lot. You're going to have to reconcile and justify your fees for doing an excellent service. And what can I say? I do this all the time. So let's say, for example, now, Alan, I'd love to send you more patients, but you're so damn expensive. And I say, look, I'm also a lot older than you. That's the way I look at them. So listen to the voice of age and reason. So a patient, let's say here's a patient, here's a woman, and we're on the North Shore here in Chicago and on the Gold Coast, and this woman decides that she doesn't like a body part anymore. She doesn't like her nose, she doesn't like her breast shape, she doesn't like her behind, or she's got lots of cellulite in her legs. So, typical MO is this woman is going to very discreetly walk around and ask her colleagues and friends and bridge party who she sees the good body part. She'll say, who's your doctor? Who did that? Did you have that done? Yes. Okay. She's then going to walk in that office, lay down the credit card and say, fix it. It's never going to be, how much is it? Say, I don't like the way this breast looks, or I want bigger, are they going to say, by the way, is insurance going to cover it? No. No, that's out of their mind. And that's an auxiliary service. We're talking here about a life-preserving, life-saving service, and these physicians are saying, what do you charge and does insurance pay? Wait a minute, is that part of your health service licensure? Is this part of what they teach you in school? You physicians have a course called Insurance 101, is to make sure you get reimbursement? We're dealing in a health service here. I think we're dealing in a health service where the patient will pay. Do you think that guy in bed, if he had the alternative of getting an oral appliance instead of wearing that, would have said, well, I think that's just beyond means. If it's presented as a health problem where it relates to his heart attack, or he has eight times the risk of a heart attack or a stroke, or he has increased risk of diabetes, depression, and dying in his sleep, gasping and choking, I think patients ought to have the alternative of paying. And then if they don't want to, that is their problem, but it has to be presented properly. Okay, that's the sermon of the morning, I guess. So let's go back to anatomy here. So now we see the pharyngeal, different views, you see different things. Superior pharyngeal constrictor, musculus uvuli, palatopharyngeal, palatoglossus, palatoglossal arch, palatopharyngeal arch, and interdigitating fibers of the levator veli palatini. Okay, so here we say lips together, teeth apart, and we want the patient nose breathing. Let's look at all the structures that we have to be concerned about. Palatoglossus, 10th cranial nerve. Palatopharyngeal, 10th cranial nerve. Superior pharyngeal constrictor, 10th. Styloglossus. Stylopharyngeus. Hyoglossus. Styloid. Middle pharyngeal constrictor. Again, interesting, 2 nerves. Geniohyoid. Mylohyoid. And so it's interesting because now you can get an idea of what's going on with behind the skin you're looking at. And I always find that fascinating. What are the consequences of what I'm doing when I'm doing oral airway dilation? To picture the golden airway there. Then looking at the tongue again. Palatopharyngeus, palatoglossus, area of the tongue innervated by the glossopharyngeal, the ninth nerve. The area of the tongue innervated by the hypoglossal, and then that's motor nerve. You also have sensory, so we have trigeminal. And so, epiglottis. In apnea, the airway occlusion occurs in inspiration. Factors essential for closure: decreased electromyographic activity of genioglossus and insufficient opposing EMG activity in the dilating muscles. Some of those muscles are for dilation. Clenching are the dilating muscles, the muscles trying to dilate the airway. Pharyngeal collapsibility factors. The lumen of the airway can be narrowed with further susceptibility to collapse with negative pressure such as created by nasal obstruction. That's what we talked about. The narrower the nasal airway becomes, the more susceptible it is to further collapse. As I said, that's a study by John Remmers. Multiple sites of obstruction are possible, and the actual site of the oropharyngeal obstruction can vary from person to person. And it's very interesting. We'll talk about that when we get to snoring, as to where the collapse really occurs. The pharynx is a collapsible tube. So in the collapsible tube, we have obstructions that are possible, such as tonsils, adenoids, polyps, allergic edema. They can cause the airway to narrow the size of the lumen. And then the pharyngeal airway can be physically obstructed by collapse of the tongue and facilitated by negative pressure, tonic and phasic activity. So this is a complicated thing that's going on, and it's nothing in this field is just a simple black and white yes or no answer ever. Factors that compensate for oropharyngeal collapsibility: clenching, bruxism, clenching, tonic, bruxism, phasic. They activate pharyngeal dilators, tonic activity of genioglossus, and then premotor neural circuits that activate pharyngeal dilators. And then we have tongue reflex stimulation. This, I think, is going to be where a lot of action is going to be seen in what we do, and we're going to talk about that. Oropharyngeal function is extremely complex. This is the point. Again, it's easy to say, define obstructive airway. We're dealing in a disease that's way more complex than just apnea. It's very difficult. If you give a name, obstructive sleep apnea, and you get rid of the apnea, you think you've got a great result. It's way more complicated than that. We hold a lot of keys to the answers, but it's not as simple as apnea. So Sam, we were talking this morning, and I demonstrated that sometimes it's gases even. So when people mouth breathe, for example, they blow off the carbon dioxide, and they don't retain as much carbon dioxide as they should have. And so you'll have the case. Patients will come in. I had a patient who went from 33 to 3. What a great result. You should be so happy with this result. I think I'm going to show it in my slides, and I'm going to write it up as a case study. The guy says, so how come I still feel like crap? The thing is that there are many complicating factors to this. And so we're going to talk about some of them, but carbon dioxide is a very important one.
Alan, can I ask a question?
Certainly.
I think it fits in right here. The discussion that you hear, I'd love your opinion about the so-called inverse relationship between bruxism and apnea, that some say you see bruxism early on, and then the mechanism for opening the airway kind of wears out, if you will, and then it turns more into an apnea. You've heard that?
I've heard that
discussion. And that sometimes you can have a severe apneic patient and they have no bruxism at all, and the sleep physicians are saying, well, there's no relationship between parafunctional activity like bruxism and sleep apnea, because sometimes we see some of our worst patients and they don't have any bruxing at all. So, they would almost deny the relationship, but others would say, well, that's because that mechanism to try to open the airway is kind of worn out and now they're left with apnea. So what do you think about that?
Well, what I think about that is, again, so I'm trying to say there's a complex problem with numerous variables other than the obvious. And so, for example, when you talk to a cardiologist, can atrial fib only be caused by sleep apnea? No, of course not, because there are patients who have atrial fib for obviously other reasons, and so they do the electrocution, they do whatever, the thermoablation, and they cure it, and the patient's happily ever after. And then they have patients with high blood pressure whom they control, and they have patients who get stents, and they control it. So to say that apnea causes the answer to all coronary atherosclerosis or coronary thickening of the artery walls, the answer to all that is that they should cure the apnea, and the answer to all high blood pressure, cure the apnea, and the answer to all atrial fib is cure the apnea. No, we're not taking their living away. We just want them to think about this as a factor, one factor in a complex problem. The problem is we haven't nailed the differential diagnosis. Of course, it's not. All bruxism isn't that. And, you know, we both know the same people who did the same study where they induce, you know, high fillings, and patients chew and go crazy and have all kinds of symptoms, and including maybe even a jaw problem. And the fact is that, yes, high occlusion can cause bruxism. That's not to deny it. But again, is that the only cause? No. Is bruxism a complex problem? Yes. Does bruxism relate to the size of the airway? Sure. And again, it's like I say with tonsils and adenoids. Kids who have large tonsils and adenoids don't all have apnea. In fact, all kids who have them taken out don't always get rid of the apnea. Kids who have small tonsils and adenoids have apnea. So sure, if you take out the large ones, it makes it easier for the kid to breathe, but they're not the cause of the problem. And everybody's looking for proximate cause all the time. There's no always, there's no never. We know that. It's just a question, what can you do to raise your confidence level so that these guys are listening when you try and have this kind of intelligent discussion with them. And so this is basically what I'm trying to say is, if you understand the complexity of the problem, you can reason together with these people. We don't have all the answers. That's what I'm saying to you. They don't have all the answers either. What we have here is a huge multidisciplinary problem that we all have to work together. And so it used to be with Jim Frickton. He would sit down at a conference table at the University, Minnesota, I think, and they'd sit down and they'd have 8 people around a table, and 8 heads are always better than one, and they'd solve the problem. Today, I sit at the clinical case conference every Friday at Rush, and this is the way they do solve problems. It is the multidisciplinary problem together. I was supposed to wait for Lee to talk about the book, but what he's going to talk to us about is, as a marketing effort, Physician's Guide to Dental Sleep Medicine. And what he's accumulated here is a list of publications, including some by me, and including some by you if you want to do it, and including a whole lot of others to document the kinds of things we're saying. So that when I see a physician, I say, hey, look, I don't want to leave this with you. You could look it over as a reference to how dentists can work together with physicians. But it's not just, hey, trust me, I'm a nice guy, and besides that, I just took you for a nice lunch. It's more about talking science with them. Just like, okay, so we have this to give to the physician, and you have all this information to take home. And this is just the beginning. I'm sure that no one can absorb everything that I have said after just having listened, and hopefully you could use this as a reference and maybe make your own book or whatever. But it's complicated stuff. That's the whole long and the short of it. And the more we have a lot to contribute to this complex problem. I didn't answer your question, but that's the best you're going to get.
Brought up the fact that they felt there was an inverse relationship between bruxism kind of early in age, and then as time goes on, the bruxism decreases as the apnea increases, because the theory was, and I haven't read all the articles, that's why I'm kind of throwing that out to you guys, whether there's much that substantiates that says you can kind of wear out the compensatory mechanism that's trying to open the airway, and it finally just gives up, and now you've got severe apnea. That's what I heard.
And it's certainly reasonable, because what we're dealing with here, when we have pain, like for example, we've all treated TMJ, I know you and I have, and so you treat TMJ and you're treating pain. And what's the source of the pain? The pain is fatigue. So to me, that's wearing them out. You're overusing them. So we're dealing in chronic overusage, and so you have fatigue. Fatigue creates the products of anaerobic metabolism, lactic and pyruvic. You palpate these muscles, they're tender. So, okay, I mean, yes, it's a very reasonable assumption. Difficult to prove. I mean, I guess, what do you do? EMG muscles, muscle testing, and see whether or lactate testing to see what the lactic acid level is in all these muscles. This is tough stuff to prove, but you know, sometimes that's what controls the studies about. So they figure out a way to test just that. They're going to test, let's say, lactic acid and superior pharyngeal constrictor muscle and draw conclusions. Maybe they're right and maybe they're wrong. Probably what they say is going to be based on data. How does that relate to what you're saying? Can the muscles fatigue all the muscles? Some muscles? Can you predict when you see a patient which muscles are going to be tender to palpation before you do it? No. Yesterday with Jan, I'm thinking she was not tender, not tender, not tender. All of a sudden, the medial pterygoids, bam, she's flinching. You know, I can't predict that. And would I have predicted bilateral or unilateral? You can't. This stuff is way too complex, and that's my answer always. It's based on having this understanding that we have a piece of the puzzle to communicate. But yeah, it's possible. It sure is, and it's a good theory. But until you do better studies, that's all this stuff is. Flexion. Neck flexion changes the position of the hyoid bone downward. So when you see these people with head forward posture, you're affecting the patency and compliance of the pharyngeal walls, and the patency is determined by the attachments to the hyoid bone. So when you see that hyoid bone out of position, you have a more tendency toward smaller airway and apnea. And the interesting thing about all this, see, we're dealing with apnea because it happens at night. These people have smaller airways during the day. Just that during the day, the nervous system can deal with it. At night, fatigue takes over. Muscles change. But maybe we have something to say when we make oral appliances so they can breathe better. And when we make them at night, maybe they can breathe better during the day. It's complex stuff. Muscles inserting on the hyoid bone. Look at this. You saw the hyoid bone on the x-ray yesterday. Now you think about what's attached to a geniohyoid, mylohyoid, stylohyoid, omohyoid, medial pharyngeal constrictor, sternohyoid, thyrohyoid, digastric, hyoglossus, and chondroglossus. Wow. Pharyngeal dilator muscles, palatopharyngeus, glossopharyngeus, genioglossus, geniohyoid, hyoglossus, styloglossus. I don't have to read you the list. But the point here, Whit, is that if all we have to know is that if the genioglossus is a pharyngeal dilator, can that fatigue? Of course. We're dealing in muscle flaccidity. So can we affect the bruxism by simply altering tongue position? I think this is what we're saying all along. Sure. Palatoglossus increases activity, the palatopharyngeal increases activity, and the levator palatini decreases activity during sleep. This is complicated stuff. Again, this is during sleep. What about during the day? And so promote airflow and counter-effect gravity in the supine position. So again, a lot of our daytime activity doesn't occur in a supine position. Muscle activity controls the position of the soft palate, the tongue, the hyoid apparatus, and posterior pharyngeal wall. All are reflex level below conscious regulation. It's under autonomic nervous system control. And so, are there protrusive tongue reflexes? We'll talk about this. Yes, there are protrusive tongue reflexes. There's one non-retrusive tongue reflex. Can these reflexes be trained? Can a protrusive tongue reflex be trained to be protrusive? You have a hook in an appliance and the tongue can't get to the lips. I'm sorry, I don't think so. And so, can you train tongue reflexes? You can train tongue reflexes if an appliance facilitates the position in which you want them to be trained. So this is important. Do we have this or don't we? That's what we're going to talk about. Pharyngeal dilating muscles promote airway patency. Their ability to dilate is severely compromised when the mouth is open. There we go. So all these things, are we going to fatigue them by keeping the mouth open? A muscle may have different mechanical effects on the airway depending on the size of the airway at the time of muscle activation. How complicated can this be? I hope you're saying, holy cow, why is he doing all this? This is so complicated, I'll never know it all. I just want you to know it's that complicated. Pharyngeal muscles can have different effects at different times when activated in concert with other muscles or when activated individually. And so, you have these studies all the time in the literature. They do PET scans. And they say, well, what's really going on in the head? What part of the brain is lighting up? And they'll tell them to do something, and they'll see one part of the brain light up. And then a half hour later, they'll tell them to do the same thing again, and a different part of the brain lights up. We don't understand this stuff. But there it is. We got to deal with it. How do we deal with it? Well, there's a certain basic level that we can interact, but we have to understand we don't have all the answers. Activation of a given muscle can have diametrically different mechanical effects on airway shape depending on what other muscles are simultaneously contracting. Activation of the pharyngeal constrictors at high airway volume results in constriction of the lumen. Activation at low airway dilates the airway. So, you know, it depends. Where in the phase of breathing are we when we see these things? Very complex. Changes in breathing mode and body position affect electromyographic activity of genioglossus. Genioglossus strength decreases with age. Pharyngeal size decreases with age. With nasal obstruction and EMG activity of masseter decreases and that of the hyoids increase significantly during sleep. Wearing an intraoral appliance alters the depressor muscles and tongue, affects the position of the hyoid bone, and works differently in mouth breathers than nose breathers. So, again, are we going to find, I'll make a statement. I find mouth breathers in whom I get a good result. So, yeah, it works. The Moses works for me occasionally in mouth breathers. I have to say, I think it works better when their mouth is shut and they're nose breathers. So, again, all these things. Am I saying to you that you should never do a Moses appliance in a mouth breather? No. If it doesn't work, I think we have to be resourceful enough to go to the ENT and say, hey, can you help me? Because it's certainly less invasive to do the oral appliance before you do the surgery. So I think it's reasonable to ask this guy, can you help me after that? And I think it's reasonable of him to deal with it. You have a question, comment? Okay.
My question is, are you implying that it's a nasal problem and therefore they're a mouth breather and the Moses appliance wouldn't help? So we need them to do some kind of surgery in the nasal area?
I'm saying to you that I have had patients who were mouth breathers in whom I didn't get the desired effect, and so I send them to the ENT, and he did it. These could have been the same referral that the ENT sends to me because he says, you know, what you do is actually more predictable and less invasive than what I do, so I'd like to try this first. And you know, again, we're dealing with a subject. Whatever we do, if you take it out and put it on the table, it's undone. It's only money. These guys, when the pain is pulling like this and regurgitating nasally, they can't give them the soft palate back. And so what we do is nice, non-invasive, it's safe, and it's only money, take the appliance out, put it on the table, and anything you've done is reversed. So I think we have an important place to play until they get a surgery that's foolproof. But yeah, I think, and again, what am I going to do? Before I send that patient, I communicate very well with that patient. I'm glad you brought the point up, because what I will do with these patients is hopefully I have some time to demonstrate a little more, but he came in at 6:45 and we did it. But I'll show you the hypocapnia. We put him on an end-tidal CO2. We measure, is this patient hypocapnic? So when they're hypocapnic, and the other thing, you'll see when you get your test back, if you look at total breaths per night and you look at total treatment time, divide number of breaths by total treatment time, you have number of breaths per minute. Rick told us the 12 to 16, 10 to 16 is normal breathing. So if on that simple metabite study you see they're breathing 20 to 25 times a night, they're hyperbreathing. If they're hyperbreathing and I test them and they're hypocapnic, too low on the carbon dioxide, I got to send this guy. He's gonna know he's got a nasal surgery case because the appliance isn't quite doing it. And so, but that's working together. I'm spoon feeding this guy the case that he should be doing. Say, hey man, the nose isn't working. They're hypocapnic, and then you start to look at hypocapnia and the consequences of hypocapnia. If you're hypocapnic and you got too much carbon dioxide, your smooth muscle is going to go into spasm. Is that important? How come these kids are all peeing in the bed? These kids that have apnea, they snore and they pee in the bed. There's a 90% chance that they have sleep apnea. You don't even have to ask anymore. You say, Ma, is your kid, mother, does this kid pee in the bed? He's 4 years old. Does he pee in the bed? Does he snore? Yes. He's got apnea. You could test them, but these are the kinds of things that we can do. And so, very important. Thank you, Richard. Okay, so what does an oral appliance do? An oral appliance increases vertical dimension by opening the bite vertically. Horizontal advancement because the tongue attaches right here at in the inside of the mandible, and the tongue advances because if you pull the mandible forward with an appliance, the tongue has to go because it's anchored right here. And then we have hyoid advancement upward and forward. And then we have oral airway dilation. You can see that this is going to dilate as a result of going this way and this way. And so this is what happens with an oral appliance. But, just not to whip a dead horse, but you can't expect the tongue to come to here if you got a hook right here.
A question, please.
Question, sure.
If with the Moses appliance in, is sleeping on the back still a no-no? Considering what you're talking about?
No. I don't assume anything because you're going to have a metabite study and it's going to tell you if it's positional or not. If it is positional, we can train position. If it is positional, hockey puck in the back of the neck or hockey ball. Street hockey puck, street hockey ball. With a street hockey ball, or we have different techniques. You can keep the patient off the back. And the weird thing is, like they say, are you sleeping on your back? No, I never sleep on my back. They don't know, and that's the thing. When we tell them, we can help them to control it better. So, what's the role of an oral airway dilator in treating obstructive sleep apnea? Enlarge and change the shape of the oral pharyngeal airway. We change the head and neck posture relative to the spinal column. We raise the habitual position of the hyoid bone relative to the cranial base. We change the axis of muscular support of the tongue, and we stimulate protrusive tongue reflexes. I do, we do, the Moses does. Not all appliances do. And as I said, I'd like to see somebody else take a picture and say, hey, this is oral airway dilation. This is what we do. I'm not seeing that. I think there's a difference between mandibular advancement devices and oral airway dilators. Okay, so what's the role of a dentist with a patient with an AHI greater than 10? So you get these studies in your office. Patient comes back greater than 10. And I take 10 in a very loose sense. Because let's say the patient's 12 and they're sleeping on their back. So Am I going to take that patient and send them for a sleep study with a 12 or a 13 when it's 80% on their back? No, I'm going to teach them positional therapy. And so this is a rough thing. But if the patient comes in and they're 30, I'm going to say, yeah, you know, you need to see a sleep specialist. Maybe. But again, you got to look at this stuff. We're not talking about treating family here. So treatment of obstructive referral and treatment of obstructive sleep apnea with an oral appliance after they send them back. And so again, if you have a nice relationship, a lot of times they'll say, well, I got a patient that's thus and such, or you fax or you can email them the sleep study from a Metabite. Say, this is what I'd like to do, and they'll say, okay, go ahead and do it. No matter what the reading is, if you've worked to achieve a relationship of trust with the docs. That's what we're talking about. The more you know, the easier it is to establish, the better it is to establish a relationship with the sleep referring docs of high trust. If you have trust, they're going to talk to you nicer, better, and spend more time with you because you're going to make them look good and they're going to help you out. And the other thing is prevention. Prevention, Rick talked about lifestyle changes. Don't minimize lifestyle changes. They're very hard. You could say to patients, go home and lose 40 pounds. That's easier said than done. Exercise, that's easier said than done. Indications for an oral appliance. According to the literature, referral for an oral appliance therapy from an MD. Don't try and rule it out. Primary to heavy snoring and an AHI less than 10. You test them. It's less than 10. If they're willing to pay for it, do it. And it's indicated. Then more importantly than indicated, we have the means to listen to that snoring and say, did that snoring stop? According to the American Academy of Dental Sleep Medicine white paper pro forma policy statement, all you got to do is ask the sleep partner, did they stop snoring? If they say yes, they did. What about all the problems with the breathing? Well, okay. The point is just, it's very easy and it's appropriate to treat. Mild to moderate obstructive sleep apnea. Mild is 5 to 15, moderate is 15 to 30. This is appropriate for us to treat if the patient wants it. The patient says, I'm not going to do CPAP. And then we have patients with failure of CPAP. No matter what you do, they can't tolerate it. And so we've been talking about that, and this happens. They can't tolerate it because they feel bloated. They can't tolerate it because social reasons. They hate it. The air leaks in the eye, the air leaks in the face. All these are problems. And so there's a difference between failure and then there's poor tolerance. And failure of UPPP, another one. And then a use of an appliance during travel. So have you ever been at the airport and heard them say, okay, all computers and CPAPs on the belt. You have to take your CPAP out of the case and put it on the belt separately. So it's embarrassing. But I've had a patient come in and he says, I'm going hunting somewhere in East Africa. And he said, I found out that there's no electricity in the base camp, so I can't take my CPAP. So can I come in and get an appliance? Yes, of course. And so use of oral appliance therapy in conjunction with nasal CPAP, this is something that's happening because, as Rick pointed out, they can't tolerate the CPAP at a pressure of 20. Can they tolerate this pressure of 5, 6? Yes. Can you help them get to that pressure with an oral appliance? Yes. What's going to be more comfortable, the CPAP at 20 or the oral appliance plus the CPAP? What it is, we have to get them to comply. We can measure compliance. Compliance with an oral appliance is defined as they wear it 100% of the time period. Compliance with a CPAP is they wear it at least 4 hours a night, 4 of the 7 days a week. And yet, Alan Peck at Pennsylvania, Pittsburgh or either one, has done a study and he's shown that if you leave the CPAP out for one night, you lose all the benefits. So wait a second, they're defining compliance so low, what? That they can justify prescribing CPAP is all it is, because they're not wearing it. And 4 hours a night, wait a minute. So what, the other 3 hours they can have apneas and it's okay? It's just, this is not making sense. what they're doing is poor scientific, they're doing science by definition rather than by scientific data. Not a good thing. So how does it treat it? It prevents collapse of the airway. We get forward advancement of the jaw. We support a forward tongue position. We change the shape of the pharyngeal airway. We increase the vertical dimension of occlusion. We correct the dysphagia. You can't swallow incorrectly. You can't swallow with the tongue out the sides with an appliance in. Increase volume of space for the tongue, and we can train the protrusive tongue reflexes if the design is appropriate, and we can alter the position of the hyoid bone relative to the mandible. Okay, focus of activity of a dentist. So in an apnea patient, we focus on breathing. We focus on the oral structures, the mouth. We focus on the tongue. We focus on the jaw relationship. We focus on the muscle function. We focus on the shape of the oral pharynx, and we focus on hypoglossal reflexes. Collapse of the oral pharynx can occur in the velopharynx, oral pharynx, or the hypopharynx. Without getting into anatomical drawings again, it's the upper, middle, and the lower pharynx. And then oral appliances work best when the collapse is in the middle, according to Ng and Sestouli in Sleep in 2006. What we found, basically, is that when we studied the sound, because we got the sound, I'll get into a lecture on snoring, but I just want to summarize real quickly because it's relevant here. What we found is that Rick showed you spectral analysis. So let's say we have a rubber tube. If you kink that rubber tube and you bend it and you get that kink, okay, so if you blow air in one side and out the other, that's going to be a very narrow sound. You're going to get one or two frequencies of sound. I'll play that for you. It's a very narrow sound. When you do a snore, yes, he showed you a series, a 30-second epic, and the snores, there were two distinct sounds in about a 20-second period yesterday, okay? And so, but the distinction was that they had this whole realm of sound. One had the sound up in the middle, and the other had the sound at the front end, but it continued on from 100 to 900 hertz practically. And so the fact is that the shape is, the sound is broad, and the shape changes. So what I did is I studied the sound at the beginning of a snore. I did spectral analysis, and I can do spectral analysis with their software in the middle of the snore, and I can do spectral analysis at the end of the snore, and I find the spectral analysis changes. So what I concluded is happening in that snore is that if you take the tongue doesn't collapse like that, as if the tongue or there were a kinked hose, so you get the narrow spectrum of sound. What's really happening in that snore is the tongue is collapsing in sort of a rolling movement, and so you have a different spectral analysis of sound at any moment in the snore and from one snore to the next. So the only conclusion is that it's happening all over. It's a rolling spectral analysis, and it's happening from a broad area of the tongue because the airway is changing its shape. And then again, if you take a deep breath, that breath goes through at different rates. The air is going through at different rates throughout the breath. So there's no uniformity. It's not like we have a horn in our throat and we're blowing the horn. That's not what a snore is about. A snore is vibration from the whole structure, at the whole length of the structure in different places at different times. And so if you take that picture of the snore, it's a lot different than when you think, oh, I can tell you where it's coming from, and we'll widen that part. Not that simple. Again, nothing simple. And so, I don't know, Ian Sestouli said that, but I think I would still choose to qualify it a little bit. Okay, and so again, clinical features alone can't identify obstructive sleep apnea. Prediction models are not accurate enough, and polysomnography is a standard of care. We have a class 3 polysomnograph in the Metabite. It's good. It's going to tell us a whole lot of stuff, and really, our offices are not tertiary referral centers. We're not getting the difficult stuff. We're picking out simple stuff in our patients. We don't need to know in most cases if they have seizures or whether they have, brain disorders. Whether it's, again, it's the patient that we're going to ask. We're not even asking the question to see is it a possibility that they have narcolepsy. So there's a whole lot of things that they need to go into a sleep center, and when they put 20 electrodes on that they find. There's a whole lot of things that we could find pretty important with the 6 electrodes or the choice of 6 electrodes out of 10 or 12 electrodes that are available to us. But whatever you say, it's all polysomnography we're doing.